So မနေ့ကတယောက်မေးထားလို့ကျွန်မဒီ slide လေးတွေနည်းနည်းထပ်ထည့်ထားရပေါ့နော်။ဘာလို့လဲဆိုတော့ biologic ဘယ်နှခုလောက်ရှိလဲဆိုတဲ့မေးခွန်းပေါ့နော်။ဆိုတဲ့အခါကျတော့ rheumatological medicine medicine used in rheumatology ပေါ့။အဲ့ဒါကို divide လုပ်လိုက်လို့ရှင် immunosuppressant target specific disease modifying agent, immunoregulatory medicine, and conventional synthetic disease modifying agents and biologics ဆိုပြီးတော့ခွဲလို့ရတာပေါ့နော် So immunosuppressant တွေမှာကြတော့သူက immurans, cell set mycophenolate, the cytoxin, cyclosporine, tacrolimus, and sirolimus. The ORIA ကြတော့ cyclosporine က very old medicine ဆိုတော့ကျမfellow တက်တဲ့အချိန်မှာတစ်ခါမှတော့မသုံးလိုက်ရဘူး so we have biologic already so usually ကတော့ nephrologist တွေသုံးတာများတယ်သူတို့transplant patient တွေမှာသုံးကြတယ်ပေါ့နော်ဆိုတော့ကိုသုံးစရာလိုရင်များသောအားဖြင့်အဲ့ nephrologist တွေရှိလို့ရှင်တော့ we ask them to take care of it ပေါ့လေ the highlighted areas are the medicine which needs to be whole for the COVID-19 vaccine. Cytoxin ကတော့ infusion ပေါ့လေ oral နဲ့ infusion နှစ်မျိုးရှိတဲ့ထဲမှာ infusion ကို cytoxin infusion ရနေတဲ့လူကCOVID vaccine ထိုးမယ်ဆိုရင်နည်းနည်း modification လိုတယ်ပေါ့နော် medicine ကို hold ထားရမယ်ပေါ့ So next is target specific disease modifying agents. We talked about it yesterday, Janus kinase inhibitors like Xeljanz and baricitinib. Those they need to be whole for the medicine vaccination as well. I'll talk about it in a little later. And apremilast, Utelza is an immune modulator. It inhibits the PDE4 and prevent the inflammatory cascade. The new development was we use it for the psoriatic arthritis patients. It works very well, interestingly, and we don't need to do a lot of blood tests. So that's and then there's oral medicine. So people love to take oral medicine compared to injectable. Immunoregulatory are good old prednisone, IVIG, plasma exchange. They work very fast. And then in the IVIG area, in the setting of infections, solution vasculitis, some patients we need to do the plasma exchange to get the immediate so immune complexကိုplasma exchange လုပ်လိုက်ရင်ထွက်သွားတာပေါ့လေဒါပေမဲ့သူကနည်းနည်း procedure ပေါ့လေဟာတွေထည့်ရတယ် line တွေထည့်ရတယ်ဘာညာဆိုတဲ့ခါကျတော့နည်းနည်းတော့စဖြစ်တာပေါ့နော်ဒါပေမဲ့we use it a lot for the very sick patients. So conventional synthetic disease modifying agents are like hydroplaquenil, sulfasalazine, methotrexate, leflunomide, minocycline, which is very old medicine, but some people still on it. Dapsone, thalidomide. Dapsone and thalidomides are like used for the rashes and the Behçet's disease, mouth ulcers, but I have not used thalidomide for any of my patients yet. Usually we share patient with the dermatologist, so they use a lot of Dapsone for the skin rashes. So among conventional synthetic disease modifying agent, methotrexate is the only medicine need a little bit of modifications or timing for the after the vaccination. Vaccination, the medicine, the vaccination guideline ကလည်းပြောင်းနေတာ3ခုလောက်ပြောင်းသွားပြီလောလောဆယ် recently in August 4th is the last one came out from American College of Rheumatology. So here are the biologic agents. So this is a question, how many biologic agents we have? So we have cytokine targeted therapy. So TNF blocker. So we have Enbrel, Humira, Remicade, Symphony, and the Cimzia, and IL-1 inhibitor, anakinra, and then we have rilunasab and canakinumab. I have only one patient who is using the Alaris for the CAPS. Yeah. And IL-5 inhibitor is the new color. Mostly this medicine is used in allergies. Allergists use it for their allergies and uncontrolled asthma, I think. I have one patient who has the vasculitis. So vasculitis patients who also have a lupus symptoms, but she has like allergies, like urticaria vasculitis patients, which I share with the allergy. So she's on the new color. So TNF inhibitor 1, 2, 3, 4, 5. We have 3 IL-1 inhibitor, 1 IL-5 inhibitor. So a lot of biologic agents nowadays, and there are so many in the pipeline as well. And here is our IL-6 inhibitor. We talked about it yesterday, Actimra, Kevzara, IL-12 and 23 inhibitor, Stelara, and IL-17 inhibitor, Cosentyx, Taltz. Those are used for the psoriatic arthritis and psoriasis. IL-23 inhibitor as well. So, you know, it's like in United States, they are all over the TV commercials. So some patients are asking, can I have that medicine? So, but I have some patients on Tremfya, but I have not used it, Skerodectoly yet. And B-cell targeted therapy is rituximab, anti-CD20. B-cell growth factor inhibitor is Benlysta, belimumab. We use it for the lupus patient. And T-cell targeted therapy is Betasept Orencia. We use it for inflammatory arthritis. So, you know, there are a lot of biologic. So let me count. How many will be 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So if you can say 18, 19, 20, and more than that, there are, you know, many other in the pipeline as well. And they are very expensive, but it works. I know that ဗမာပြည်မှာလည်းသုံးနေကြတာပဲဘယ်ဥစားတော့မရှိဘူးလို့ပြောတယ် Actimra ကိုမေးကြည့်တော့ country rep တော့ရှိတယ်လို့ပြောတယ်နဲ့တူတယ်เนาะအဲ့လိုမျိုး distributor ရှိတယ်လို့ပြောတယ်အခုတော့မပြောရဘူးအရင်ကတော့ distributor ကနေတစ်ဆင့်ဝယ်ရတယ်လို့ကြားတာပဲ So I'd like to talk a little about vaccine guidelines. I highlighted some of the medicine that needs you know, like modification for the vaccine, meaning some medicine needs to be whole after the vaccine. So it was recommended that rheumatology patients or people who are taking the medicines, immune suppressants, are high risk and higher chance to be sick and hospitalized. So vaccine is recommended. There's no contraindication because patient has rheumatological disease or they are on immunosuppressant. But some chose not to take the medicine because they fear that they're gonna get side effects from it. However, you know, some patients actually flare up after the vaccine, joint swelling, joint pain, and etc. more than others people. However, benefit outweigh the risk, so we recommend it. Right now, ဒီမှာဘာတွေဖြစ်နေလဲဆိုတော့ vaccine မထိုးစင်တဲ့သူရှိတယ်ဆိုတော့သူတို့က excuse ပေါ့လေသူတို့မှာဒီ immune suppressant တွေတောက်ထားတယ်ဒါကြောင့်မလို့ vaccine မထိုးခြင်းဘူးဆိုပြီးတော့ exemption letter ဆရာဝန်စီကတောင်းကြတယ်ဘာဖြစ်လို့လဲဆိုတော့အခုဒီမှာ United States မှာ employer တွေက vaccine ကို mandatory လုပ်နေကြပြီ including healthcare worker ပေါ့နော်ကျမလုပ်တဲ့နေရာမှာဆိုလို့ရှိရင် vaccine ဒီမှာမထိုးလို့ရှိရင် September 30th နောက်ဆုံးထားပြီးထိုးရမယ် at least one shot ကိုထိုးထားရမယ်မထိုးဘူးဆိုလို့ရှိရင် unpaid leave နဲ့ 45 days then after that that person will be terminated and still then they are like about 10% of the doctors or 5-10% of the doctors are not vaccinated and so that will be interesting to find out. So and the other thing is it's like the vaccine 2-dose vaccine are recommended rather than Johnson & Johnson vaccination. However, there are patients who are already on the Johnson or already got the Johnson & Johnson vaccine because it's a one dose, then they prefer not non-messenger RNA. The problem right now is we are giving like, it's like a third dose for the people who are immunosuppressant. So we don't know what to do with the Johnson & Johnson people as of now, but I'm pretty sure that there will be some more guideline coming out. So antibody testing recommended not to be tested because we don't know that what is the protected level will be. Apparently, one of my friends tested, yes, his antibody level go up, but that does not mean that he will be protected because we don't know we don't have enough data to say that what is the protected levels of antibody. So here is the detail. So if the patient is taking Plaquenil, Otezla, IVIG, prednisone less than 20 milligram a day, we don't need to do any holding of medicine. They can just go get a vaccination. Interestingly, the Imuran, sulfasalazine, leflunomide, oral cyclophosphamide, Cytoxin, TNF blocker, all those the biologic TNF, IL-6 inhibitor, and the belantamab, we don't need to do any modification for that vaccine. However, if the patient is on CellCept and methotrexate, the Tesla JAK kinase inhibitor, beta-cell, cyclophosphamide IV, we need a modifications. We need to hold the medicine so after the vaccine. Used to be, we were told to hold it a week before, a week after. They are like a lot of complex, but this is the updated one, and you only need to hold it a week after each dose of the vaccine for methotrexate. And the main thing is rituximab. It's like if you patients has already got the rituximab today, that person that cannot get the vaccine for like about 5-6 months. So we do it at the end of the cycle, then wait for a month, then they can get another Rituxan infusion. So the new guideline now, we are giving like a third dose for the people who are immunosuppressant, meaning not including the hydroxychloroquine. So it's like those people, most of the people who take the immunosuppressants will get the third dose. And after the third dose, they were asked to hold the medicine for 1 to 2 weeks. Here they said that if it is disease activities is quiet disease, they don't have any active disease, then they can hold the medicine for 2 weeks, because studies are showing that they don't produce antibody compared to the people who are not taking immunosuppressant. So the big thing is rituximab, some of the medicine, the methotrexate, CellCept, JAK kinase inhibitor, beta-cell, and IV Cytoxin needs adjustment. So usually patients are, asking the rheumatologist, so we have to answer them. So this is the same thing, saying that people who are on chemotherapy, dialysis, taking the immunosuppressants, chemotherapies are have a immune response might be reduced. So third dose, and there's a confusion among like third dose and what is the booster, what is the third dose. So third dose meaning for third dose is for the people who are immunocompromised, HIV, cancer, our patients who are on immunosuppressant. It can be given a month, basically a month, 28 days after the second dose. For the booster, for every patient who receive Pfizer and Moderna, booster can be given 8 months after the second dose. So for example, I have my second dose in January, so I can get my booster dose done in September. So we are in our institution, we are in the process of starting the booster for the healthcare worker, starting on the September 20th this month. Okay. Any questions so far? Oh, there's medicine for that. Actemra. Half-life. We use the half-life. The Actemra, either injectable or the infusion. Infusion is giving like every 4 weeks. So it's like however, tocilizumab is under this, IL-6 inhibitor is under that cytokine inhibitor. We do not need to modify for the vaccination. Okay. So cytokine inhibitor, no need adjustment. So that's like comes into the majority of the biologic, except that beta sep and the JAK kinase inhibitor. Okay. So next is like the basic of how to diagnose, how to when to suspect our rheumatological disease. So basically, clinical is a key, and then exam finding to look differentiate the synovitis versus deformity from the osteoarthritis. And the blood tests are helpful if the clinical setting or clinical symptoms fit with that. But we have to keep in mind that our blood tests, ANA can be found in the normal population, in 5-10% of normal population. And so the same thing with the rheumatoid factor, CCP. We have seen the patients with the blood test positive, but if they don't have a joint inflammation, we tend not to treat with the medicine. We just monitor. So when I see the patient, the first questions will be, it's like they are already, by the time we see the patient, they already have a whole bunch of blood tests done. And, so it is easier for the rheumatologist to figure it out. But as a primary care doctor or the GP, you will be the one who has to figure it out. Do I send these patients to the specialist or not? So the helpful information, so how long it's been going on, it's start out suddenly or like slowly, or sometimes people can have it that comes and goes symptoms. The one joint swell up. It's like 2-3 days later, they are fine after taking the anti-inflammatory medicine. And then a few months later, another joints have a swelling and they got better. So for those patients, what we call is palindromic rheumatism, comes and goes symptoms, and then it's like and eventually they started to having the more joints inflammation. Some patients woke up one day suddenly and they couldn't move, all joints are swollen. So then that would be very frightening for them. It's like they are worried that, oh, am I going to end up on the wheelchair? What is going on? The distribution of the joints is very important as well. The rheumatoid arthritis, we have different distribution. The metacarpophalangeal joint, MCP joint, PAP joints are more involved, and they mostly the symmetrical. Both sides are involved. Sometimes patients don't read the textbook, so they have only one joint swelling. It's like those things can happen. And usually we say that objective joint swelling. Sometimes they will feel it, it's like they feel tight and stiff. However, there's no obvious swelling on the examination, then we can say that, this is inflammatory arthritis. And the other key feature is morning stiffness. We all feel stiff in the morning. It is part of the aging, it's like, but usually the stiffness usually takes like less than 15 minutes, 5-10 minutes, or even like, 5 minutes, or when you get out of the bed, usually it goes away. But for our patients, inflammatory arthritis, they feel stiff and they couldn't move, especially in the morning, like they couldn't make a fist. And then they couldn't turn on that faucet, like when they wash the fits. And then sometimes they give a very good history. It's like yeah, they put hot under the hot water and they feel so much better. Or they went into the have a hot shower and they feel better. Those are the signs of inflammation. Sometimes people are like, they can't even turn on the doorknob, turn on, it's like they can open the door, they can turn on the car because, they have hard time holding the key or put the key in and, it's like turn the key in. But most of the, it's like those are the features of inflammation. And they feel worse at rest and they feel better after the activity. So sometimes they say that, it's like they feel very worse in the morning, and then as they are started to move around, they're feeling better and better. And at the end of the day, after dinner, they are sit down on the couch watching TV, and they started to feel stiff again. And at nighttime, they feel so much pain. So that's the difference. If it is the osteoarthritis or mechanical pain, you have more pain with the activity. So when you are at rest, they too feel better. So mechanical pain and inflammatory pains are, totally different. So this is the pictures. So you can see that in the metacarpophalangeal joint, there is an inflammation and swelling. You can see the bogginess, and then when you press on it, it is soft. However, on that right-hand side, osteoarthritis, they look big, but when you examine it, it is hard, not soft to touch. Okay, and in the osteoarthritis, you can see that DIP joint involvement and PIP joint involvement. On the this it's like rheumatoid arthritis, swelling is more in the MCP joint and also in the wrist. So this is in writing: soft synovial swelling, and then also subluxations, and then swelling in the MCP joint, swelling in the wrist, and PIP joints, and early swan neck deformities, which is so in that DIP joint, there's some deformities already. So osteoarthritis is habitants and Boucher notes, more like a knotty, bony structure. You can see it on here. So this is a sausage toast. So if once you see it, you will never forget. And it's so you have to, it's like look for it. You have to know what to look for. This is like swelling of the toes. And then psoriatic arthritis, typical features. Sometimes it can present as a rheumatoid arthritis, symmetric joint swelling, but most of the time they are like, more like one joint. The whole finger is swollen like a sausage. So it could be in the thumb, it could be in the, it's like index fingers, it could be in the toes. And sometimes psoriasis is not obvious. If it is in the elbows and the knees, then it's like it is obvious. But it is sometimes also only in the scalp or inside the ears, and you can't see it. And it can be also found in the Rider disease. Now we call it reactive disease after the infections, like sexually transmitted disease or food poisoning. Some patients can have a joint inflammation. So this is the skin rash of the lupus. So there's like the discoid lupus. You can see that it is like already like involved in the deeper structures, and that could develop scar. And sometimes you can see the blister, and mostly in the sun exposed area. And you can get the history that it can get worse with the sun exposure. So this is the malar rash on the right side, and you can see that nasal sparing of the nasolabial fold in this area. They don't have it. And one of the differential diagnosis, so most of the patient who come in to see us with a positive ANA, they are very nervous when they have a rash, but most of the time they have rosacea. It is not, it's like typical malar rash, but when here people tend to Google it and they thought they have a lupus when they have a positive ANA and they have a joint pain and they have a rash. So that is very stressful though for them. So this is a question, what is the most likely diagnosis? This is the lupus patient who is on hydroxychloroquine, and this is her hand look like. You can see that she has a swelling or look like ulnar deviation on her right hand, and this is it's like the X-ray. It looks deviated, it's like however there's no damage or erosion found on the X-ray. So it is overlap syndrome with the rheumatoid arthritis and lupus, Skerodectoly, erosive arthritis related to lupus, or Charcot arthropathy. So that is the Charcot arthropathy because it is involved in that, this is another patient. Usually it's because of the loosening and lengthening of periarticular structures. It is not that because of the joint problem, it is more like a tendons loosening up. So if you're on the examination, it can be corrected. If you pull it, it can be corrected. But if you let it go, then it goes back to that, it's like ulnar deviation. And X-ray finding, there's no erosion. So that can be the erosive osteoarthritis, and they don't have a pain. So. And people with the rheumatic fever can have this as well. I have never diagnosed rheumatic fever here, very rare over here. But in Burma, probably there are a lot of people with the rheumatic fever. So then the testing, like I said, blood test positivity is helpful when the clinical findings associated with it. However, the ANA is a most order, test, in my opinion, and that's what we do for every day. We have to see patient to tell them that they don't have lupus. That give a lot of anxiety to the patients because when the ANA came back positive, they Google it, and first thing come up is lupus, and they got, they look it up, and all those symptoms of lupus, like, it's like you can die from it. Actually, there are some patients who have just rashes and joint inflammation. There's no like psoriasis or nephritis or any other problem. However, it's like they worry to the extreme. And like I said, those antibody can be found in the 5 to 10% of normal population. So we usually ask, do they have a photosensitive rash? And then also we look it up the urinalysis and protein urine creatinine ratio to see whether they have a kidney inflammation. We look it up CVC and differential to see is there any leukopenia, anemia, low platelet counts, or it's like then photosensitive rash to determine, and examination. Pain is not that it's like the symptoms, but usually the swelling of the joints. It's like arthritis is a itis, meaning swelling. Arthralgia is a pain. And some of the patients with the lupus tend to have a pain, all over pain, like a fibromyalgia. But it's like we have to look for the joint inflammation in order to make that diagnosis. And some patients can have like dryness in their eyes and mouth sores, and the hair loss, meaning bald spots and etc. The Skerodectoly is very distinct features. The last picture, it did not show that the tightening of the skins in that previous picture. Usually Skerodectoly presented as like very tight, thick hands. They could not make a fist and feel very swollen and tight. So this is a picture showing the tophi, or like, it's like a gout, uric acid crystal deposition in the ears. And this is like second picture is the typical first MTP joint podagra. And then you can see that swelling, inflammation. And the side picture is usually the tophi. So you can see the white chalky material on that, it's like those tophi. And sometimes patient might say that they are like white stuff coming out. If you put it in the slides and look at the microscope, you can see the crystal. So this is the X-ray showing the erosion. Oops, sorry. Erosion of the first MTP joint. So gout is inflammatory condition. It is very painful. You can't even touch it when they are actively inflamed. But if you don't do anything, usually get better within a week. But it is not pleasant to have this kind of pain. And that usually if we don't take care of it, they may end up like this, erosions of the joint. Joints are destroyed because they have inflammations and the bones are eating up. You can see it on this second finger as well, like it's like a it's like the erosions in that, it's like fingers. So this is like showing that, it's like uric crystal. So key point, usually here, the risk factors are because they are like obese. So high body mass index, metabolic syndrome is a very high risk for the patients, or sometimes people drink beer. So end product of beer is uric acid. And if they are obese and add with the beer, You know, it's like that's double, you know, double risk or double whammy. They produce more uric acid because they are big, and they drink beer, and end product is a be, you know, it's like a uric acid. And some patients with the chronic kidney disease are the high risk as well, because they cannot excrete that uric acid and they accumulate in the body. And the new finding is people who drink like soda, like you know, like Pepsi, you know, it's like cola, Coca-Cola. They are that's like can trigger that, you know, it's like gout attack as well. That can cause a high uric acid level. And if they have too much uric acid, they can have like kidney stones and chronic kidney disease. The treatment, we do use colchicine first and control the inflammations, but sometimes colchicine is not enough, then we use glucocorticoids, prednisone. And once the inflammation is, if a patient has like 2 attacks per year, we treat with that uric acid lowering agent. And then we tend to use colchicine for 3 months to prevent the flare up. So once you start that allopurinol or febuxostat, uric acid lowering agent, before inflammation is controlled, patients will keep getting flare attack after attack after attack, and they usually say that your medicine is not working. Actually, which is not, you know, it's like timing, and if we don't control the inflammation, they will tend to, you know, it's like get the flare up. So what I usually say is, you have this much uric acid, we give them medicine and it shake off the poo, and they tend to, you can have like flare up. In order to prevent that, we usually give colchicine for like 3 months. Anakinra, we can use it, but it's very expensive and you have to do it every day. So I have used one patient, but you know, it's like after that, you know, uh, recently I have not used any patient. I have not used this medicine for the gout. So this is like the picture of interphalangeal dermatitis, which is like the skin rash in between the joint. It's not on the joint. And the right side is Gottron papules, the rash on the joint, which can be found in people with the polymyositis, dermatomyositis, I mean, meaning muscle weakness, skin rash. Sometimes those people can have interstitial lung disease as well. Not only in the hand, it can have it in that, you know, it's like the short sign is on the neck, and then around the eyes, you know, it's like they have that rash. We have to make sure that they don't have cancer, because dermatomyositis patients can have an underlying, you know, malignancy. So the key point we like to make is like, you know, it's like do not miss the organ life-threatening condition associated with rheumatological disease, because we are in the pandemic. Does not mean that we have to think out of, you know, it's like does not mean that everything is from COVID. We have to think outside of the box. If patient presented with the rashes, joint inflammations, difficulty in breathing, and kidney problem, that could be vasculitis. It's like, and we have to make sure that infections has ruled out, especially for the gout. It comes in, it's usually have it in the one joint. They are red and swollen and inflamed. They have fever. They have high WBC. So we have many times patient were hospitalized and they consulted the, you know, it's like orthopedic, do the, you know, they took them to the ORA, do the washes and all those things, and finally turned out to be that, you know, a lot of gout crystal they found on that, you know, it's like when they open it up. The key is a good history taking, and thorough physical examinations is key factor to make the right diagnosis. ANA or autoantibody tests only give supports in the right clinical setting. And especially with right now, COVID patients, after the COVID, they have long haul symptoms and then they have joint pain, muscle pain. They don't feel good. They feel stiff. So, it's like the primary care doctor or GP tend to check those serology. I have seen a few patients, they have rheumatoid factor, low titer positive, ANA positive, RNP positive, and then a referral is generated. But when you ask so many questions and examination, they don't have a synovitis. It doesn't sound like inflammatory, and that started after the COVID infection. So, it's like we have to be careful with that COVID infection, any kind of like infection that, non-specific immune stimulation can trigger the blood test positivity. Yesterday someone asked about this medicine cost. I Google it and it's drug.com said that, it's 200 2000, it's like dollar if you don't have an insurance. Here it works with the insurance system. Patient has insurance and they were hospitalized, usually paid or taken care of. But I'm not even sure that this medicine is approved to use in COVID. But some studies I found that they stopped doing that because of the side effects people are having. So I see the question, which is better, allopurinol or febuxostat in the uric acid lowering? Each and every flare-up, should we give colchicine up to 3 months dose of colchicine? Okay, so first question, allopurinol, febuxostat, which one is better? Allopurinol works unless that they develop like it's like hypersensitivity reactions. We usually start with the allopurinol. It works, but our patient population, some of them might take in the Imuran. You cannot take Imuran and allopurinol because that will increase that in the Imuran. It can cause the Imuran toxicity. It increases the level. So if it is the case, then I may use a febuxostat, which is expensive, and most of the insurance don't cover as well. So most of the allopurinol, the people will say that, oh, I can't take it. I have a stomach problems, this and that. We tend to start out. But most of the time they said that allopurinol does not work, meaning they keep having the flare up. So I have to convince them that let's try it with that, it's like either with the prednisone or colchicine. Colchicine, we used to give like, for the flare up, you give, it's like a 1 tablet first days, and then you can take another dose. You can take it another dose until like you have diarrhea. It's like to me it is like brutal. When you are having joint inflammation and you can't even walk, and then you give colchicine to have a diarrhea, that is brutal. So what I usually do is like we give colchicine up to 3 months, meaning when you start the allopurinol. It's like not that every flare up. Oh, the other key thing is we recommend not to stop allopurinol during the flare up. In old trend, it's like somehow people have that fixed idea, including the doctors. Still, they go to the ER. They were told that, oh, stop the allopurinol. And so we started all over again. So never stop allopurinol or febuxostat when, flare up. Keep taking it and give that colchicine. I give like 0.6 milligram BID. And then sometimes even the 0.6 milligram BID, people can have stomach issue, diarrhea or stomach upset. Then you can give like 0.6 milligram daily. And in our institution, we only give 12 pills of colchicine for the flare up. So you can start out with that, 0.6 BID, until that flare up is over. 3 months is only for when you first diagnose and when you start that allopurinol or febuxostat to prevent the flare up. And then we usually give like 0.6 daily. Any other questions? I think that's, all for me.
မှာဟိုလေ chat box မှာတော့မတွေ့ဘူးကျွန်တော်တို့လေunmute လုပ်လို့ရအောင်ဒီဆရာမတို့ unmute လုပ်လို့ရအောင်ကျွန်တော်ဒီဘက်ကနေပြီး setting ကိုပြင်လိုက်ပါမယ်ခင်ဗျဟုတ်ကဲ့ပါဓာတ်ရိုက်မေးလို့ရအောင်ပါဟုတ်ကဲ့ဟုတ်ဆရာမတို့အားလုံးလေ chat box ကနေမရိုက်ဖဲနဲ့ unmute လုပ်ပြီးတော့မေးလို့ရပါတယ်ခင်ဗျဓာတ်ရိုက်မေးလို့ရပါတယ်ဟုတ်ကဲ့ပါဟုတ်ကျေးဇူးအများကြီးတင်ပါတယ်ဟုတ်ကဲ့ပါ
ဟုတ်ကဲ့ပါကျေးဇူးအများကြီးတင်ပါတယ်အရန်ကိုအကျိုးရှိပါတယ်အရန်ကို support ဖြစ်ပါတယ်ဟိုလေးဟိုဒီ uric acid uric acid level ကိုလေ routinely check ဖို့ recommend လုပ်လားဟိုပါဘယ်လိုပြောမလဲ allopurinol လည်းသူက control ရနေရပေါ့နော်အဲ့လိုမျိုးဆိုရင် routinely yearly သွားတင်လားအဲ့မေးချင်ပါတယ်မှာအဲ့ဒါလေးဟုတ်
Okay, very good question. So Maru ga di ma another important thing ali flare up ဖြစ်နေတဲ့အချိန်မှာလေ uric acid က check လုပ်လို့မျိုး joint swelling တွေ flare up ဖြစ်နေတဲ့အချိန်မှာ uric acid မ check မလုပ်တာကောင်းတယ်ဘာဖြစ်လို့လဲဆိုတော့တစ်ခါတလေကျရင်သူတို့က ER သွားတော့ ER သွားတဲ့ခါကျရင်သူက uric acid check လိုက်ပြီးတော့ normal ဆိုရင်သူက patient ကိုပြောတယ် you don't have a gout because uric acid level is normal even though their big toe is swollen. So Amaru control the inflammation first. So let's say that you see the patient, right? The first diagnosis and control the inflammation, then check the uric acid level. So then you know that this is the accurate level. So let's say that uric acid is 10. So you start the allopurinol. We usually check the uric acid level again in like 3 months until like we get to the goal. We like to have a uric acid level less than 6. Study have been shown that uric acid level more than 6, you still can get the flare up. So every 3 months, and then if they are still stable, then maybe you may want to check it like yearly. It's like here people tend to get like CBC, it's like yearly checkup, and so uric acid can be included. That's a very good question. Another questions, how long methotrexate to be whole after vaccination? Aku atit trade the latest hogaga to got puraro the 1 week after, it's like so you have to hold a week after the each dose. Okay, but if the patient's going to get a third dose for our patient population, then you have to hold like 1 to 2 weeks. And Celsep and cytoxin has to be whole when the patient has COVID. Yes, so that's what we were talking about it yesterday with Joe and Xuan. It's like I tend to hold them because I don't want them to suppress their immune system too much. It's like so, and then you can argue that even though you hold the medicine, the medicine will be in their body, because if you stop the Celsep, it will be stay in the body for like at least a month or so, and cytoxin as well. So I will hold those medicine. And then some of them are like they are so sick and that's like automatically whole. Hospitalized patient, for sure, we hold all those medicine. Okay, those are the very good questions.
Audience imagine a compliments level is siluyalamdi. Dialogue TV.
ရန်ကုန်ကဆရာမတွေများသိမှာမသိဘူးเนาะဒီမှာစစ်လို့ရလားလို့မေးတာပါ complement C3 C4 စစ်လို့ ရသလားလို့ကျမတော့တိကျမသိဘူးရှင်ရန်ကုန်ကအခြားဆရာမတွေရောသိမလား
ဆရာမမီမီ unmute လုပ်လိုက်တာလားမသိဘူး sorry ဟုတ်ကဲ့ဟုတ်ရတယ်လို့တော့ chat box မှာဖြေထားကြပါတယ်အမဟုတ်ကဲ့
ဟုတ်ကဲ့စစ်လို့ရပါတယ်
ကျေးဇူးပါ
မဝင်းမတင်ဟိုပါကြောင်းလိုက်အောင်ပါဟိုပါလေသူ cancer နဲ့ဒီ immunosuppress တမားတွေမှာ vaccine လေးအကြောင်းနည်းနည်းပါသွားတယ်လေနော်ပို့လို့ရတယ်ဆိုရင်ဟာလေဟိုအဲ့ဒါလေးကိုကျွန်တော်နည်းနည်းလေးဟိုပါ audience ကိုအခြား immunosuppressive patient lecture လေးမရှိတော့အဲ့ဒါလေးကိုတော့ကျွန်တော်ဟိုပါ3ချက်လောက်တော့ပြပေးလိုက်မယ်လေနော်ဟိုပါ
very good yeah go ahead yeah
တော့ဘာဖြစ်လို့ပါဒီပုံမှန်ကတော့ကျွန်တော်တို့ဒီ root of thumb ကတော့ဒါပြီးလို့ရတယ်ပေါ့နော် vaccine ကိုပြီးချင်အောင်ဆိုထိုးလို့ရတယ်ဒါပေမဲ့ဒီ guideline အရာကတော့သူကဒီတချို့ဟာလေးတွေကိုတော့ခွဲထားတာပေါ့ပထမတစ်ခုကတော့ဒီ patient က bone marrow transplant လုပ်ထားတဲ့လူပေါ့လေဟိုလိုမျိုး allogenic သို့မဟုတ် autologous transplant လုပ်ထားတဲ့လူဒါမှမဟုတ်လို့ရှိရင်ဗမာပြည်မှာတော့မရဘူးပေါ့နော်ဒီနိုင်ငံခြားမှာတော့ဒီ cellular therapy လို့ CAR T-cell therapy ယူထားတဲ့လူတွေဆိုလို့ရှိရင်တော့အနည်းဆုံး3လစောင့်ရမယ်ပေါ့လေ after and မှာအဲ့ပြီးလို့ရှိရင်တော့ vaccine ကိုထိုးလို့ရတယ်ပေါ့နော်အဲ့ဒါကကြတော့ cancer patient တွေမှာနှစ်ခုခွဲထားတယ် hematological malignancy ရှိတဲ့ patient တွေ solid tumor patient တွေပေါ့ hematological malignancy ရှိတဲ့ leukemia လို့ဟာမျိုး very intensive chemotherapy ယူနေတဲ့လူတွေကြတော့သူတို့ကအရန်ဆိုးတဲ့ neutropenia ရတဲ့ခါကြတော့လေသူတို့ neutrophil count recover ဖြစ်တဲ့အချိန်မှာထိုးတာပို့ပြီးတော့ကောင်းနေဘူးเนาะဆိုတော့ဟို chemotherapy ယူပြီးတော့သူတို့ကအကြာကြီးအဲ့လိုမျိုး neutropenia ဖြစ်နေတာဆိုတော့သူတို့ကအဲ့ဒီအချိန်မှာ vaccine ထိုးလို့ချင်း effective မဖြစ်တဲ့အတွက်ကြောင့်မလို့ဒီ neutrophil count normal ကျွန်တော်တို့ကတော့ဒီ 1.5 ဆိုလို့ရှိရင်တော့ဒါ neutropenia မရှိတော့ဘူးပေါ့နော်ဆိုတော့ဒီ neutrophil count recovery ရတဲ့အချိန်မှာဒါကောင်းပါလေ intensive chemotherapy ယူနေတဲ့လူတွေပေါ့နော်အဲ့ဒါတချို့ကြတော့အဲ့လိုမျိုးဟိုပါပေါ့လေ long term leukemia တော့ leukemia ပဲဒါပေမဲ့ chronic lymphocytic leukemia လို့ဟာမျိုးဒါမှမဟုတ်လို့ရှိရင် chronic myelocytic leukemia လို့ဟာမျိုး maintenance treatment လောက်ပဲ oral treatment လောက်ပဲယူနေတဲ့လူတွေကြတော့ဒီအချိန်မှမဆိုထိုးလို့ရတယ်ပေါ့နော်ဟိုကျန်တဲ့ patient တွေကတော့ဒီ solid tumor အဲ့လိုမျိုးပေါ့လေ cancer lung cancer တမဒီလိုမျိုးဒီ colon cancer တမအကုန်လုံးကတော့ root of thumb ကတော့ဘေးအချိန်မှမဆိုထိုးလို့ရပါတယ် radiation ယူနေတဲ့ patient တွေလည်းထိုးလို့ရတယ်ပေါ့နော်အဲ့ဒါကူကကြတော့ချိုးကြတော့နောက်ပိုင်းမှာ immunotherapy ယူနေတယ်ပေါ့ immunotherapy ယူနေတဲ့ immune checkpoint inhibitors လို့ခေါ်တာပေါ့လေ immunotherapy ယူတဲ့လူတွေကလည်းဘေးအချိန်မှမဆိုတော့ထိုးလို့ရတယ်ပေါ့ကူကတော့ surgery ပေါ့ major surgery လုပ်ထားတဲ့လူတွေကတော့ချက်ချင်းထိုးလို့ရလားဆိုတော့ဒီ surgery ကလည်းဒါ immunosuppressive ဖြစ်တဲ့ condition ဖြစ်တဲ့အတွက်ကြောင့်မလို့သူတို့ကတော့ surgery လုပ်ပြီးလို့ချင်တော့အနည်းဆုံးတော့ a few days တော့စောင့်ခိုင်းနေပေါ့နော်ဒါမျိုးပေါ့နော်ဘယ်လိုကောင်းဆိုတော့တပတ်ပေါ့လေတပတ်လောက်ပေါ့လေအဓိကတော့ဟာပါအဓိကတော့ hematological malignancy patients တွေမှာတော့ severely very intensive chemotherapy ယူနေတဲ့ patient တွေဆိုလို့ရှိရင်တော့ neutrophil count တွေ normal ပြန်ဖြစ်တဲ့အချိန်မှာပေါ့နော်နောက်တစ် cycle မယူခင်ပေါ့အဲ့ဒီအချိန်မှာပြီးတော့ကောင်းနေပေါ့နော် transplant လုပ်ထားတဲ့ patient တွေကတော့3လလောက်ဆောင်အောင်ဒါလေးပါဟုတ်ကဲ့ကျေးဇူးပါ
So, Mama, quick question here. Earl, I who sorry, the at the end of the cycle, my baby or below someone the Maruso retoxin so in the last someone the the vaccine Toby oh sorry, the last sound be ma retoxin be so aram you or Sheila.
Yeah, အဲ့ဒါတော့ကျွန်တော်အမအသေးစိတ်တော့မသိဘူးเนาะသူရဲ့ cycle life ပုံဒီမှာပေါ့เนาะသူတို့ရဲ့ cycle တွေကဘယ်လောက်လဲသူတို့ရဲ့ spread ကဒီဟို recovery နဲ့သူက recovery ကနေပြီးတော့ပြီးတဲ့ဟာနေပြီးတော့ recovery ရဖို့ဘယ်လောက်ထိကြာလဲလက်ဆောင်လို့ချလို့ချင်းကောဟိုပါပေါ့เนาะဒီ condition ကခုနပြောသလိုပို့ပြီးတော့ဒီ hematological malignancy ကပို့ပြီးတော့ဆိုးနိုင်မလားသူရဲ့ timing ပေါ့နော်ဆိုတော့အဲ့ဒါကြတော့ one specific နဲ့တော့ဆိုင်သွားတာပေါ့နော်သူရဲ့ condition နဲ့သူရဲ့ severity နဲ့ပေါ့လေဟုတ် yeah generally ကတော့ကျွန်တော်တော့တစ်လားထိတော့စောင့်မှာမဟုတ်ဘူး probably they will probably wait for
yeah But not also throughout they are very so sick, and if we don't do anything, then that will get worse. So
ပြီးတော့နောက်တစ်ခုကလည်းသူတို့ကဘေးအချိန်မှာရှိနေတာလေပေါ့ induction phase မှာရှိနေတာလား consolidation phase မှာရှိနေတာလားအဲ့ဒါကတော့ specifically ဆိုင်အောင်ပါပေါ့နော်ဆိုတော့
yeah, oh, more complex, huh?
နောက်တစ်ခုကတော့အရေးကြီးတာကတော့သူကတော့နောက်တစ်ခုကတော့အဲ့လိုမျိုး cancer patient တွေမှာကတော့ဖြစ်နိုင်လို့ရှိရင်တော့လေဒီ caregivers တွေနဲ့ household close contacts တွေကို vaccination လုပ်ဖို့ကလည်း very important ပေါ့
ဟုတ်တယ်အမတို့ဒီဘက်မှာလည်းသူပြောထားတယ်ဒီမှာ specifically သူတို့ကဒီ psycha the household member တွေကိုလောက်ခိုင်းဟုတ်တာပေါ့ဘာလို့လဲဆိုတော့ကိုကထိုးထားပေမဲ့ကိုအိမ်မှာတယောက်ကဖြစ်သွားရင်အဲ့မလွယ်ဘူးပဲเนาะဆိုတော့ yeah
အရင်တော့ဖြစ်ခါစား guideline တွေ think clear မဖြစ်ခင်မှာတော့ကျွန်တော်ဆိုရဲ solid tumor patient ထိုးမယ်ဆိုလို့ရှိရင်တော့သူတို့ကိုအဲ့လိုမျိုးပေါ့နော် second cycle မယူခင်လောက်မှာပေါ့လေကို blood count recover ဖြစ်တဲ့ချိန်မှာထိုးခိုင်းနေပေါ့တော်တော်များများပေါ့နောက်ပိုင်းကတော့ဒါဒီအဲ့ဒီချိန်မှာထိုးလို့ရတယ်ဆိုတော့အခုကတော့အဲ့ဒါမျိုးမလုပ်တော့
yeah အခုတော့အကုန်ပြန် third dose စပြီးတော့ပေးနေပြီပေါ့သူတို့
okay
ကျေးဇူးပါ
နောက်တစ်ခုအမဟိုဒီထဲမှာ IVIG ကိုထည့်ပြီးတော့မပြောထားအောင်နော်အမဟို IVIG ပေးတဲ့လူကတော့ရှားပါတယ် rheumatology မှာညီမဒီ statin induced myopathy နဲ့ patient တယောက်ရှိတယ် IVIG အခုတော့ဟိုမဖြစ်တော့ဘူးเนาะပြီးသွားပြီဆိုတော့တခြား DMARC ကိုပြောင်းလိုက်တယ်အဲ့ဒါဆိုရင်ရောဘယ်လိုငါဟို guideline တွေ့လားမသိဘူးဒါမှမဟုတ်လို့ရှင်လေ cancer မှာရှိလားမသိဘူးကျော်လျောင်းတို့ oncology က guideline hematology
အမဟုတ်တယ်ဒီမှာ IVIG မပါဘူးဟုတ်တယ်
အခုဒီက ICCN ရဲ့တကယ်ဟိုအထက်မှာလည်းတော့ငါအသေးစားတော့မတွေ့
IVIG က antibody ပဲ immunoglobulin ပဲဆိုပြီးတော့သူတို့ကဟိုထဲမှာမထည့်ထားအောင်နဲ့တူတယ်နော်
normally ကတော့ rheumatology ပေးရတဲ့ condition ရှားပါတယ်အဲ့ပြီးတော့ဒီ statin induced myopathy ကလည်း very rare ဆိုတော့ important မထည့်တာ hematology oncology literature မှာရှိမှမသိ
မပြောတာဘူးเนาะအဲ့ဒါပြန်ပြီးမေးကြည့်ရမယ်ဒီမှာ so yeah
ဟုတ်ကဲ့အမဟုတ်ကျွန်တော်တို့2ရက်လက်ချပေးသွားတယ်အမကိုကျေးဇူးအများကြီးတင်ပါတယ်အမဟုတ်ကဲ့အမဗာများဖြည့်ဆွတ်ပြီးပြောချင်တာများရှိသေးလဲခင်ဗျဟုတ်ဟိုဆရာမမင်း
လက်ထောင်ထားတာတွေ့တယ်
ဗာများပြောမလဲခင်ဗျဟုတ်ဆရာမမင်းမေးကြရှိရင်မေးလို့ရပါတယ်ဗျ
Thank you for very comprehensive lectures. My question is regarding yesterday lecture. Is related to the asymptomatic cryoglobulinemia because we are working in this UNOPS harm reduction program. So it's focused on injecting drug users who has a lot of HIV hepatitis C co-infections. So regarding this, I'd like to know about any management for the asymptomatic cryoglobulinemia. Thank you.
If patients don't have any symptoms, we treat the underlying condition, right? So IV drug user, do they have hepatitis B, C, or HIV? Then treat that, underlying condition. But unless that, patient started to have rashes, joint inflammation, blood in the urines, and etc., I don't think we do anything about that cryoglobulinemia. Do you have any other suggestion, ကျော်ဝင်းရွှင်
ဟိုအမပြောတာဟုတ်ပါတယ်ဟိုအကယ်၍ patient symptom ရှိရဆိုလို့ရှင်တော့ rheumatoid factor စစ်ကြည့်တာတို့ complement C4 ကိုစစ်ကြည့်ရလို့ဆိုလို့ရှင်တော့အဲ့ဒီဟာတွေကusually rheumatoid factor တက်နေမယ် C4 ကနည်းနေမယ်ဆိုရင်တော့နည်းနည်းclosely monitor လုပ်ရင်တော့ကောင်းတာပေါ့နော်
yeah so အဓိကတော့ symptom ပေါ့နော် symptom ဖြစ်လာရင်တော့ဟာဖြစ်တာပေါ့ maybe UA ပေါ့ urinalysis Sanka sometimes they might not have a symptoms for their kidney involvement so periodic urinalysis
Thank you.
ဟုတ်မှာကျေးဇူးအများကြီးတင်ပါတယ်မေကွန်းလည်းမရှိတော့ဘူးဆိုတော့ဟိုအမနှစ်ရက်ဟိုကျွန်တော်တို့တခြားပေးခဲ့တာအတွက်ဟုတ်ကဲ့အမတခြားဗာများဖြည့်ဆွက်ပြီးမှပြောချင်တာမရှိအောင်လည်းခင်ဗျဟုတ်ကဲ့ပါ
မရှိပါဘူးအားလုံးကိုကျေးဇူးတင်ပါတယ်ဒီကကြော်ကြော်ဆိုးနဲ့ကျော်ဝင်းရွှင်နဲ့WHO organizer အားလုံးကျေးဇူးတင်ပါတယ်it's a like a well like a thought out and well planned events and I'm glad to be part of it thank you
Thank you
ဆရာတို့အားလုံးလည်းကျေးဇူးအများကြီးတင်ပါတယ်ဟုတ်ကဲ့ကျွန်တော်တို့မနက်ဖြန်မနက်၈ နာရီမှာလေဆရာကျော်ကျော်ဆိုးရဲ့ endocrinology lecture လေးရှိပါတယ်ခင်ဗျအဲ့တော့ဆရာတို့အားလုံးမနက်ဖြန်မနက်၈ နာရီမှာပြန်တွေ့ကြပါဟုတ်ကဲ့ပါကျေးဇူးအများကြီးတင်ပါတယ်အမကျေးဇူးတင်အများကြီးတင်ပါတယ်ဆရာတို့ဟုတ်ကဲ့ပါ
okay
ကျေးဇူးတင်ပါတယ်